Good evening, everyone. Thank you so much for joining us for this May installment of the School of Nursing Education Connection webinar series. I'm Beth Nugent, and I'm the Senior Associate Director of Development at the School of Nursing. The Nursing Education Connection is a monthly webinar series, and it's meant to keep you connected to the work and the amazing accomplishments of our faculty, students, and staff. So we are all very grateful for all the support that you give the school. Just a couple of housekeeping items before we introduce our speaker. We would very much like your participation during this webinar, so we invite your questions and your comments. If you think of a question for the speaker at any time, please feel free to include it in the Q&A section. Answer as many as we can at the end of the presentation. And during this evening's webinar, we will also be sharing relevant links with you in the chat box, which you can view by clicking chat along the bottom of your screen. And finally, if you're interested in supporting the School of Nursing, we would ask that you consider donating. There's a link to give to the school's general fund in the chat, and we will share that link again at the end of the webinar. Thank you. So without further ado, this evening, we're pleased to welcome Dr. Laura Gultekin. Dr. Gultekin has spent the past several years partnering with community agencies to develop and implement research aimed at improving the health and well-being of families experiencing homelessness and housing instability, as well as training community organizations and health systems in trauma-informed care. Through qualitative, multidisciplinary, community-engaged research, Laura is working to develop, implement, and measure community-sustainable programs that positively impact housing stability and the life circumstances, especially exposed to trauma and violence, that contribute to family homelessness. Dr. Gultekin is also working to increase interdisciplinary trauma-informed services for all communities in Southeast Michigan. Dr. Gultekin, thanks so much for joining us today, and I'll hand it over to you.
Thank you. I am thrilled to be here, and I hope that folks will raise some questions. I also hope that this presentation will help people think about trauma-informed care maybe in a different way, raise some questions or some interest in it, and get you perhaps interested in learning more about trauma-informed care. So, I want to start by acknowledging the many people who have supported the work that I do and my many collaborators, including my colleagues in the Cascade team at the University of Michigan, in particular, Dr. Monroe Kramer, Dr. Kuzunoki, and one of our most recent graduates of the DNP program, Emily Shao, who created some of the slides that are in this presentation today. The Coalition on Temporary Shelter, also known as Creating Opportunities to Succeed, which is a large family shelter in Detroit, the largest family shelter in Detroit. And the photos that you see in the presentation today are from their organization. And my other school mentors, including Dr. Brush, Dr. St. Arnold, and Dr. Kainlow. Some objectives for today, I'm going to tell you a little bit about my research trajectory working with families experiencing homelessness, and then talk a bit about trauma-informed care because I can't help myself. And then we'll talk a little bit about those principles and how nurses can apply trauma-informed care to reduce harm to patients who are vulnerable to homelessness and housing instability. So when I first started, this was decades ago, back in like 2009, as a graduate student looking at the experience of family homelessness. I was diving into the federal data, and these numbers go up and down year to year. But we see too many people who are experiencing family homelessness. The thing that stays consistent within the federal data every year is that most of these households are led by a single female with 1 to 2 children. Oftentimes, those children are under the age of 5. It's a time when people are most vulnerable to housing instability when their kids are quite young. We also see that folks experiencing homelessness and housing instability are often members of historically marginalized identities. So folks who are Black, Hispanic, and Latinx are overrepresented in this experience. Other interesting data that I found from HUD and that came up over and over was that 72% of families experiencing homelessness have no diagnosed disability. That 67% of families entering family shelters are not considered survivors of domestic violence, and that only 6.4% of families experiencing homelessness are considered to be chronically homeless. And I found this really fascinating because as I started doing focus groups and kind of diving into an understanding of this experience of family homelessness, um, the individual stories weren't matching the data. And so that really drove me in a qualitative direction to better understand what was happening with families experiencing homelessness. So my first work with focus groups was trying to do a needs assessment for a community that wanted to develop a health clinic within their shelter system. And when we started talking to the folks that were there, discovered that was not actually a pressing need at the moment. They had some access to services already. Um, but what they were sharing with us is that they weren't being heard, that they didn't have services or access to services to support recovery from the many traumas that they had experienced across their life, and that there was really nobody that was listening to their needs. So I developed some areas that I really wanted to know more about. Specifically, what were those life trajectories, the events, and the experiences that were contributing to family housing instability? And then where were those points? What was it that people thought, hey, if I had had support, where within that trajectory could we have disrupted that pathway into housing instability? Could people pinpoint moments or people or opportunities or places that they could have maybe change directions? And one of the interesting things that came up pretty early in these discussions was that a lot of folks who were coming into the shelter for the first time were coming into services because they'd talked to a nurse, because they were in the hospital for an illness or an injury or for care for their children. And it was a social worker and or a nurse who came to them and said, you know what? Let me help you find some support. There's nothing wrong with getting help. It's really important. And so nurses tend to be some of those frontline people who really impact trajectories for families who are needing additional services and support. Um, So my initial dissertation work really looked at qualitative studies, or was developing a qualitative study with a narrative approach, where I had interviews with folks, asked them, I met with them twice. In the first interview, I asked them, how did they get where they were? Tell me all about your life. Tell me about the big events, the positive events, the negative events, how you got here. Um, and then before I came back to see them again, I would gather that into a comprehensive story to the best of my ability, and then type it up, bring it back, and we would sit together and go through it. And they would correct where I misunderstood things, um, make sure that all of the details and the facts were correct for them, and that it felt like their story. We then spent time identifying themes together. So, what felt like the big important life events that impacted where they were, that they thought, oh gosh, if somebody had been able to get me out of this spot, um, or if something could have impacted or changed this situation, that would have made a difference. So, there was a content and thematic analysis to all of this. And ultimately, what happened with this process was, while it was not an intervention, it was just a process of gathering this qualitative data. Folks said, this felt really good. Everybody came back for their second interview, and that was despite tremendous challenges to transportation, phones. I went to meet a lot of people where they were, but they returned my calls. They reached out. They wanted to be involved in this process, and they felt really positive when they received that write-up of their second interview, where they got to see what their story was and kind of talk through it and see it presented to them as something that was valuable and important. Um, so there was a therapeutic aspect to that hadn't been tapped into with the population. Of course, we all know about talk therapy and the values of talk therapy, but oftentimes we forget the value of just having a conversation with our patients and on how that can contribute to an understanding and a hearing of their life events and what that means. So this led me to want to better understand what was going on um, with families and develop some interventions. Sorry, I'm jumping around here for a second. Let me get back to what's on this slide. So this is the themes that came up that emerged from that initial work. And this was a lot of conversation about histories of domestic violence. So of the 16 individuals that I talked to, 15 of them talked about long histories of growing up in households where there was domestic violence, witnessing violence toward their mother, toward their grandmother, toward their aunts, whatever that primary figure was in their life, they were seeing them be harmed within their partners' relationships. And then they went on to have relationships with folks where they were experiencing intimate partner violence. But they weren't reporting that on entry into the shelter. And there were lots of reasons for that. Part of it was that you can't receive services for domestic violence unless you're actively fleeing, which means having left someone within the last 3 months. So having these long histories of domestic violence and intimate partner violence was setting them up for having a reduction in resources, but there wasn't really a way to recoup that loss or to get treatment for it in the system that exists. They talked a lot about chronic instability, that experience of moving from house to house as a child, living with grandma for a while, then going and staying with auntie, and then moving in with a parent's friends, of taking on early parenting responsibilities. So this was not often teen pregnancy. This was really taking care of younger siblings, cousins, other children in the household when the adults were not able to do so. And that they had really limited social support, that the friends that they had kind of burned those bridges or burned those relationships by the needs that they had in maintaining their housing and preventing entry into the shelter. In addition to that, we talked a lot about educational interruptions. There were lots, as you can probably imagine, with someone who is growing up in a household where there's frequent moves, where you're taking on parental responsibilities at a young age, that often means you're not making it to the classroom. They experienced households where there were significant family substance use disorders, parental separations related to broken relationships, parental incarceration, homicides, loss, just lots of big traumas going on. And then there was a normalization of trauma and adverse childhood experiences, or ACEs. So that they felt like this was everyone's experience of the world, that it was really normal to grow up in a household where, your parent was not there 5 nights a week because they were out getting high, where nobody talked about it because everyone was experiencing it, and you didn't want CPS showing up on your door. The other thing that came up that wasn't part of this theme, this came from both the focus groups and these conversations, but the experience of going into the shelter itself was a tremendous trauma. Sometimes just because it was, that realization of, here I am in this place where everyone is feeling very desperate and lost. They had built up the idea of entering the shelter to be something pretty terrible. But in addition to that, oftentimes the folks who were working in the shelter, who were their first contacts, were folks who had recovered from homelessness on their own. And so they were there now working in the shelter and didn't always have maybe the emotional bandwidth to manage interacting with someone who was in an acute situation where they had just lost their housing. And so a lot of the women shared stories about coming into the shelter and being shamed for crying, or being told, what is this, your first time? And feeling like they were being told that everyone just expected them to be unhoused, and that nobody expected anything positive in their life. So it led me to want to develop some interventions. So my colleague Denise St. Arnault had developed a clinical ethnographic narrative interview. We modified it to the clinical ethnographic narrative intervention and made it trauma focused, and worked with COTS to deploy it. So it was a series of 4 interviews with participants. The first one was very much like that first interview I had done in my dissertation work, where we were just having conversations. Tell me about your life. The second was coming back to them with their narrative and them having them draw a lifeline, And then the third and the fourth sessions were going back and validating kind of the highs, the peaks in their life and the valleys in their life, and how they got from those low places back up to those high places, identifying their how they made meaning of the life experience they had and what they were doing in terms of help seeking and really kind of promoting what processes they had in place to build out additional help seeking. Um, the participants, again, this was one that was really, really well received. Everybody showed up for every session. It was kind of shocking, again, with folks who have lots of transient and high stress life experiences going on, to have people return, to have 100% engagement in a process is wonderful and surprising. But there were some challenges along the way. So, one, it was a really time-intensive intervention. I said there were 4 sessions. Each session, so occasionally there were short sessions that lasted about 30 minutes, but for the most part, most of the intervention time was about 60 to 90 minutes per session. Um, in addition, we had partnered with a local agency that provided mental health services in the area, and we were planning on having direct handoff, warm handoff, so that if someone said, hey, I'm realizing, right, this was a help seeking, help promoting intervention. So if someone said, hey, I think I do want to talk about this more, I do want to get involved in therapy, can you help me find somebody? We could hand them right off to this agency. The intention for the agency was that they wanted to receive our patients immediately. The reality was, when we started doing handoffs to them, just like every other agency in Southeast Michigan, an urgent handoff was 3 weeks. So it took 3 weeks for them to get to intake. And there just isn't infrastructure in Michigan, really across this country, for good mental health services that are outside of crisis mode. So it was really disappointing. There's also limited funding available to support this kind of intervention. And we went back and forth on who should be delivering it and how it should be delivered, and ultimately just kind of went, well, if we don't have the infrastructure, the mental health support services, then even if we motivate people toward help seeking, we're not really doing what we want to do. But the thing that came through over and over was, gosh, there's got to be something else that as nurses we can do and promote and help people have more positive interactions that promotes this help seeking in a more natural way and in numerous settings, so that we can connect folks with services as those needs arise. And that really led me to trauma-informed care. So trauma-informed care is a universal approach. It's something that we should be doing for every single person we encounter in our work. And it's not just for healthcare, it's for education, it's for social work, it's for really any forward-facing agency that's providing any sort of service to folks. It is a strengths-based approach that utilizes people's own personal agency and promotes empowerment and the ability for people to recover from their past traumas. It does not require disclosure. It assumes that lots of folks have lots of different traumas, and nobody has to disclose that they've been harmed to receive kind care. There are some assumptions. I'm going to talk about those assumptions in just a minute. And the biggest thing with trauma-informed care is that it really promotes resiliency and agency, so that people can heal and recover from their past traumatic events. So trauma. I know everybody on this on this webcast knows trauma. You probably have slightly different definitions, though. We all have slightly different definitions of common terms that are based on our own experiences and backgrounds. So, for example, I worked as a peds ICU nurse for the first 10 years of my career before going back to school. And as a graduate student and professor, I studied the effects of trauma and adverse childhood experiences on individuals and families specific to that experience of homelessness and housing instability. So when I hear the word trauma, I carry different definitions of it depending on what hat I'm wearing and kind of what mindset I'm in. As a PICU nurse, trauma meant car crashes, meant house fires, non-accidental injuries, and I can still appreciate that those things are trauma. But my definition as a scholar, an academic, is really much broader than that and includes not only those acute injuries, but the lasting effects and the complex trauma that happens to folks across the lifespan that's often unseen. So I'm going to give a couple of definitions that aren't meant to pretend like you guys don't know what these words are, but it's to create a shared vocabulary to align our definitions. So I'm going to lean into the Substance Abuse and Mental Health Services Administration, and their definition of trauma is an event, series of events, or set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So there are three words in here that are highlighted, and those are known as the three E's. The three E's are the events. These can be isolated single things, like, again, car crashes, house fires, natural disasters, acts of terror, but they can also be complex traumas like domestic violence, intimate partner violence, household injuries and abuse that are happening to folks. The experience, that's all very personally. So sometimes what one patient or what you or I may view as a trauma might not be what someone else perceives as a traumatic event. Again, with that process of normalization, it can be more complex to determine what is considered a trauma by an individual. And then the effect, and those effects can be, wholly impacting an individual across the lifespan. We think a lot about trauma and acute reactions to trauma in terms of fight or flight, and I'm sure everybody is really familiar with fight or flight, but we have kind of a larger range of reflexive responses to trauma. Fight and flight, right? Those are those gross motor responses. We can all think about how that feels in our body with the high heart rate, our blood pressure going up, that flush that comes along, just that ready to really run and move. But it's also associated with kind of that decrease in higher level brain function. Same with freeze. So we see a freeze reaction, which is actually a hyperarousal reflex, even though it doesn't sound like it, where we see a loss of physical control. There is that deer in headlight, right? Is just not being able to move in a bad situation. It's also often associated with dissociation or shutting down to protect the psyche from the events that are happening in the moment. We do see a lot of hypoarousal reflexes as well. And I think of a lot of the patients that I see on a regular basis having some of these hypoarousal reflexes kind of being triggered all the time. And that can look like faint or fawn. Faint is one we're pretty familiar with, right? Patients kind of just going down. The one thing to point out with any of these reflexes is there are degrees of seeing the reflex, just like we see with, anatomical reflexes, and we have a range of normal responses. Um, there is no one single, like, it's people who are in fight or flight are not always physically running or punching. They might just be in an agitated state and really hyper aroused and ready to move. But same with faint and fawn type responses. With the faint response, so I gave a lot of COVID vaccines during the pandemic, and I know a lot of my colleagues probably on here today did as well. And you probably are quite familiar with that faint response and how that looks when it is fully enacted in folks. It is not a consciously aware behavior. It is something that just happens. Fawn is very similar, and it's one that's less studied, but it's one, I think it's more appropriately referred to as appeasement. And it's a way of preventing the injury, or in fact, really just stopping self-protective behaviors in order to avoid conflict with someone. So it's a way of silencing and repressing the self. We talk about that because those are related to the window of effective tolerance. So all of us have a window of effective tolerance. Most of the time, we hope to be living within that window of effective tolerance. This is where we are in homeostasis. This is where our body likes to be. It's where it's functioning at its best, where our brain is working in a well-connected and coordinated manner with the rest of our body. But sometimes stressors or big traumas can happen and push us into states of hyper or hypoarousal. The challenge with this is anytime we get into a state of hyperarousal or hypoarousal, the effort that it takes for our bodies to kind of calm down, reassure safety, get our autonomic responses back under control and back into that state of optimal arousal requires work. That work is known as allostasis. Um, the more our body is called upon to get from a state of hypoarousal into that state of optimum arousal, the more allostatic load we develop. And that has long-term consequences. It increases our risk of inflammatory illnesses and conditions. It increases our risk of not being able to heal or prevent illness. So it really has some impressive long-term consequences on the body. And the more time we spend in these states of hyper or hypoarousal, the more easily we're triggered to be in those states, and the harder and the more difficult it is to return to that state of optimum arousal. And so you may see that you have patients that you're working with who seem to always be hypervigilant, angry, agitated, very quick to respond in a way that seems excessive, and it's really part of their survival reflexes that's kicking in. They're in a traumatized state. Um, Even when we don't perceive what they experience to be a trauma, right? They may be misunderstanding or misinterpreting that situation. So why is that? So some of that has to do with changes from chronic exposure to stress hormones like cortisol and adrenaline. It changes, prolonged exposure to cortisol changes how we process information, how we remember things and integrate memory into our behavior, and how we align our behaviors with the way we want to behave. Long term, we see toxic changes to the brain. We see inhibition in some of the growth and recovery of our um, brain cell connections. And yeah, some difficulty again in that thinking and processing. And same with adrenaline. We have those bursts of adrenaline. We see changes in memory and emotional perception, and how it really can alter how people physically experience events. So that constant exposure to higher levels of cortisol and higher levels of adrenaline results in this constant alarming. And you guys know if your phone goes off at a strange time and you can't find it and it just keeps ringing, or your bedside alarm clock is going off and you can't turn it off, right? It's really hard to function with that noise going on. It's really hard to distinguish what's a real threat and what's a normal stress. And it can be really difficult to access the higher parts of our brain to get our behaviors to align with the ways that we want to behave. So again, those changes we see, we oftentimes when folks are experiencing chronic stress or recurrent stress and trauma or complex trauma, we see an increase in the amygdala, which is the alarm center. So that alarm is triggered more easily and it's harder to turn off. The hippocampus, that filing center that helps us organize our thoughts and organize memories, gets smaller and has less ability to integrate with our frontal cortex, which is our thinking center, which gets us to behave in ways that really align with who we want to be as people. The other thing that I find to be important, and I work with pediatric populations in Detroit at a Head Start. And so I love this slide, but it helps me too when I'm thinking about what's going on with my patient and why sometimes my patients may have a lot of trouble with their emotional regulation, with their thinking or behaving when they're feeling really stressed out, right? So most of the time, we hope that we are not in a survival state. And when we are in a survival state, we are focused on the most basic um, of behaviors, right? Staying alive, getting regulation, which is sleeping, eating, bathrooming, all of those things, maintaining some control over those. So we have very little time to focus on the social emotional states and cognition. With children, we see that they have difficulty when they are focused on survival and regulation. They have really a lot of difficulty in developing pro-social emotional behaviors, and they may have difficulty with learning in school. And I see that fairly often in the Head Start program where I work. Um, when we're able to get folks out of that survival state, so in a state where they're feeling safe, where their needs are being met, where the basics, they're not worried about where they're going to sleep for the night, where they're getting food or rest or anything like that, then they can focus on their own social emotional well-being and thinking, right, and learning. So overall, the more and more we learn about trauma, the more we realize that it's really impactful on morbidity and mortality. So, trauma-informed care, this is our toolkit, right? This is our way of helping us shift from thinking that, oh gosh, what's wrong with you, to, hey, what happened to you? It shifts our thinking from um, thinking that folks who are being reactive and loud and maybe not having full control of their behaviors, thinking that they are having abnormal responses, and helps us recognize that it's not their behavior that it's abnormal, it's the trauma that triggered their behavior that's abnormal. Their response is actually a survival response, and it's expected, but we can help them regulate and figure out how to be in more control of that. So again, going back to this slide, trauma-informed care, this is our universal approach. It's strength-based. It does not require disclosure. I'm going to go very quickly through the next few slides. This is just to give you a sense of what trauma-informed care looks like. And some of the important things. I hope that folks if this tickles your interest, if you don't know a lot about TIC, that you'll reach out, and I will be happy to share some more information with you about it. So the 4 R's of trauma-informed care, really realizing that there's a widespread prevalence of trauma and understanding those paths for recovery, recognizing how trauma affects all individuals, including the patients or service participants that we're seeing, our organization and our system, and including our workforce, right? We know that nurses are traumatized, not just by the work that they do, but often by their own personal histories that they're bringing into their work. That we respond by fully integrating knowledge about trauma into our policies, procedures, and practices, and that we resist re-traumatization. So re-traumatization, I will say, while working in the ICU, and we do this all the time in all sorts of settings, right? We mislabel symptoms as personality flaws or disorders rather than traumatic stress events. We are overly authoritative or confrontational rather than trying to de-escalate situations. When someone puffs up, we puff up back, right? That's part of our own trauma response. We oftentimes judge, we don't believe, or we blame survivors. All of this causes re-traumatization. So when we have some awareness of why people may be behaving the way they are, it becomes way easier to not, again, label them as pathologic, but label the trauma that's driven their behavior as the pathology, not the behavior that we're seeing, and helping them get more mastery over those behaviors so that they can get their behaviors to align with who they want to be and how they want to present themselves. SAMHSA presents 6 key principles of trauma-informed care. I find these to be super important in the trainings that I do. I do a lot of trainings with community organizations. I'll talk about that a little bit more in a second. I'm just going to introduce these really quickly. So we've got safety. This includes environmental and physical safety and emotional safety. For patients, this is something that looks like maximizing control over their lives, making sure that they have good understanding of what it is that we're asking them or to do for themselves, and really making sure they're the ones who are driving decisions in their lives. For staff, safety looks like maximizing control over the service environment and minimizing risk. And it really, I think the thing that is super important working in hospital environments, in clinic environments, in wherever we're enacting nursing, is that we have plans for safety and we practice those plans for safety. That we develop trustworthiness and transparency, and this is an ongoing process, that we have processes where we are clear and able to maintain, do the things that we say that we're going to do, and we do them in a way that patients don't wonder why we're doing them, right? We communicate the limits of our confidentiality. We make sure that people are having understanding of what's going on, and they have truly informed consent in any sort of process that's happening. That we offer opportunities for peer support. So not every agency has the opportunity to offer peer support programming. However, we can refer people out to trusted community partners who do offer opportunities for peer support. Having time and space to interact with people in a positive manner that's non-judgmental, respectful, reciprocal, and empathetic is really helpful in building resilience and coping skills with traumatic events. That we develop collaboration and mutuality. So this is really about balancing those power differentials that happen in healthcare contexts. That we learn about our patients and what they want and why they might want things done in a particular way, and what that is, how can we help them get to where they need to be um, in a way that makes sense for them. That we offer opportunities for power, voice, and choice. Again, this is a trauma-informed care is a strength-based approach to care. So attention really has to be given to promoting empowerment, voice, and choice, and celebrating those small achievements, offering opportunities to really for patients to direct their own care, and supporting opportunities for personal agency. And finally, this is the sixth of the principles, and probably the most important. And it's really some of the ways that we have to address and be accountable for the historical, cultural, and gender issues that impact our patients and the way that they access care. So being aware of our own biases, conscious, unconscious, and otherwise, so that we aren't inflicting harm on patients or passing judgment. Um, or impacting how other folks interact with them. That we move past cultural stereotypes and biases, that we offer gender affirming care to our patients, that we leverage the healing value of traditional cultural connections, and then we recognize and address the historical trauma so we don't continue to inflict them. When I think about how this looks in actual action, and when I work with agencies in the community, some of the things that I find to be really important is realizing that the impact of trauma on our patients and the impact of trauma on ourselves and our colleagues, and really taking some time to recognize how trauma might be enacting in our own lives, and changing the responses that we would typically have. Recognizing again that trauma response in our own patients and in ourselves, feeling what it feels like so we can start to recognize it and de-escalate for ourselves when needed. Responding to our patients by aligning ourselves with the goals of the moment and using trauma-informed principles, and then resisting re-traumatization by not pathologizing those trauma responses and supporting resilience in our patients and fellow clinicians. So the benefits of trauma-informed care, when we think about it at the recipient level, is really that recovery and resiliency that happens when we enact trauma-informed care. We provide space for people to maintain agency, to engage in help seeking, and really help them move forward into trauma-focused or trauma-specific interventions as they need them, and know that they can feel safe coming back to us and build positive, healthful relationships with us. When we think about the workforce, I think this is also really important as we see more and more nurses leaving the workforce. Trauma-informed care really helps us attend to safety. It helps us attend to secondary trauma and recognize the risk of burnout, and acknowledge that, we all need recovery and healing as well. That trauma impacts us all in our everyday work, and that it's worth treating. So, all of this comes together. I know this feels like kind of maybe two separate topics. It's really not. Trauma-informed care is really about how we get everybody in a place where we are supporting the most vulnerable among us. So my work right now is really focused on creating more trauma-informed clinicians. I work a fair bit with colleagues in the school in creating content both for our students and for community organizations in the area. We are teaching students about trauma-informed care. I know in our graduate programs in particular, the content is weaved into a lot of the different hands-on classes and didactic learning as well, that we're weaving trauma-informed care into our interprofessional educational opportunities as well. We've got a mini certificate in trauma-informed care to try to get students working more with educators and social workers to think about what trauma looks like in our pediatric populations. Again, trying to stem some of these multi-generational traumas that are leading to these really awful downstream effects of housing instability, disrupting them earlier so we can get children and families the help that they need to recover. And then helping to train organizations in trauma-informed care. And I've been working with actually the whole Macomb County. My colleagues and I are providing trainings for their health department, the Department of Corrections, everybody associated with Macomb County to try to get them at least at a baseline level of trauma-informed care. And we're hearing some really positive results with that. There's a lot more work to be done to better build out, what's the best practices in terms of trauma-informed care. I think there's a lot more work to be done to make us more interprofessional and make sure that we've got our physician colleagues on the same page, because one of the biggest challenges with trauma-informed care is we've got to have a whole organization involved. So that was a lot of information, but I'm going to move on to any questions, I think.
Thanks so much, Dr. Gultekin. That was wonderful. Great presentation and wonderful work that you're doing. So thank you so much. Yes, we will jump into a little bit of Q&A. We have a couple of questions that we're going to ask, and I would just encourage any of the guests to also put any questions that you might have or comments into the Q&A box at the bottom of your screen. So we'll get started. Can you share a little bit more about how the trauma-informed care fits into health systems and clinics, and who needs to use trauma-informed skills?
Yeah, so as I just kind of mentioned, so trauma-informed care is an approach that really requires commitment from every single person in an organization. And that's one of the biggest challenges with it. So we need everyone from the security staff, the janitorial staff, anyone that any patient or service recipient might encounter needs to have some awareness of what trauma is and how it impacts people. Because you never know when someone is going to have kind of the start of a reactive response. We want that all the way from, the front door of the building up to the C-suites, including the CEOs, CFO, and COOs. It requires that full institutional commitment, and it's really why we're seeing so few health systems that have truly trauma-informed processes in place. There are some really good recommendations out there from SAMHSA that include addressing the 10 domains of the organization. And I won't get into all the specifics on that at the moment, but yeah, if folks are interested, check out SAMHSA's website, just put in SAMHSA and trauma-informed care, and there's some really great quick guides that provide some overviews of how that can be enacted.
This question is, how does a universal approach to care like trauma-informed care make a difference in the individual lives of people who are vulnerable to unstable housing and homelessness?
Yeah, so one of the issues that was raised over and over by the families that I interviewed were that homeless or housing unstable they had this chronic instability. They had difficulty pinpointing a single moment. But like I was mentioning earlier, oftentimes they identified that there was a nurse or a teacher or a social worker, or there was somebody somewhere along their life that made them feel heard and empowered to seek help. Sometimes that help-seeking response was crushed by no follow-through, which is why, again, we need a fully trauma-informed approach where there is trustworthiness and transparency and mutuality and collaboration to build the follow-through so that people can really can develop their own good, positive help-seeking behaviors and resiliency. I think nurses all the time are using trauma-informed skills, but they may not have the language. I think the more that we learn and think about applying these terms and using this terminology very specifically, the more we help people feel less shame over their trauma responses and recognize that there is life after trauma.
Wonderful, wonderful answer. I have one more question. Oh, no, maybe two. We just got another one. Give me just one moment here. What are the areas that need further research in relation to TIC and working with families that are unhoused?
So yeah, lots of areas that still require research. So we need better tools to assess the application and receipt of trauma-informed care. In all kinds of settings. So we need more extensive access to trauma-informed mental health services and recovery programs. As I was kind of alluding to earlier, we do have a mental health system that's barely meeting the basic needs of most of our patients in the US. It is really quite strange. So we need to find better trauma-focused and trauma-specific services along the way, but we also, as clinicians, have the ability to introduce the concept of trauma-informed care, help people understand what's happening in their own bodies and their brains when they're experiencing trauma and trauma responses, so that they, again, can have some understanding of what they can control, what they might be outside of their control, and how they can build skills to recover more quickly from trauma.
Wonderful. I have one more question. I've been trying to integrate ACEs awareness and TIC in a pre-licensure program. I would love to see TIC in undergrad programs. What are your thoughts?
Absolutely, I completely agree. This is something that we are seeing. So our sophomores right now do have some trauma-informed and ACEs education. I think ACEs are essential. The challenge, of course, with ACEs is that oftentimes we're screening for ACEs and then we go to refer people for trauma focused or trauma specific intervention because they've exposed some ACEs and the services don't exist. Like I was talking about this challenge of not having a lot of mental health services out there or not having the robust mental health services that exist. But it shouldn't be stopping us from assessing and starting to introduce and starting to again integrate those behaviors. Um, I think when we start applying trauma-informed care to the education of all nurses, all healthcare clinicians, all social workers, all educators, and we create that baseline, that understanding of what trauma is and what it looks like. We create more resilient clinicians, and we, reduce that risk of burnout down the road. We create healthier systems for patients to receive services and where they feel safer and more engaged in seeking their own recovery.
List of our questions today. Thank you so much. We really appreciate you taking the time to connect with all of us tonight. And I want to thank everybody that has joined us as well and contributed to the discussion. So thank you. Once again, I'll just note if you'd like to make a contribution to support the School of Nursing, we just ask that you consider donating, and you'll find a link in the chat box to do so. You'll also see Dr. Gultekin's and my contact information in the chat box, so you can feel free to contact Laura with any questions directly, or feel free to reach out to me anytime with questions about supporting her work. In the coming days, we'll be sending you a follow-up email, and it will just include a brief survey. We would really appreciate your feedback. It helps us a lot in planning our future webinars. So if you could please just share some topics you'd like to hear about, we'd be happy to move forward on those next year. And one last thing before we end today and for the season, I'd just like to take a moment to thank Sabine Almendrez for all the work that she does behind the scenes to make this webinar work. So thank you, Sabine. We couldn't do it without you. Like many of you, we'll be taking a summer break, but we hope that you'll join us when we return in the fall. Details and registration will arrive in your inbox in mid to late August. So thank you so much again for joining us, and have a great summer. Good night.